At this time, I would like to turn today's program over to Tricia Petruni. Tricia, you may begin.
Thank you very much to everybody who's been able to join us thus far. I apologize for the slight delay. Those of you who are webinar experienced know that it's par for the course, but I swore to start time, so I apologize for that. So welcome officially to our webinar on family planning for key populations in Asia, being co-convened by USAID, PEPFAR, and FHI 360. Before we start, I just wanted to make a clarification about what we mean when we use the term key populations. Defining it as people who are affected by HIV, so people who are either at risk for or already living with HIV. And we know that key populations affected by HIV in Asia have an unmet need for effective contraception, high risk of unintended pregnancies and abortions, and suffer from a general lack of access to comprehensive health services. To organize this webinar with some specific objectives in mind, which I hope that you can now see on the screen, to generally describe what we do already know from existing data, the contraceptive needs and preferences, to further dissect and discuss the challenges to, but also the facilitators for how we strengthen the linkages between family planning and HIV. And then also to just explore USAID's current programming and experiences with regard to integrating family planning and HIV in Asia. Now, to accomplish these objectives, we organized this agenda for you today. We'll start with your facilitator to move us through. With some welcoming remarks from Marta Levitt from USAID Office of HIV/AIDS, then a very brief presentation providing an overview of what we know about family planning use and needs among key populations in Asia. And turning it over to Susan Paxton, who's going to provide her perspective on the reproductive health experiences of women living with HIV in Asia, followed by Jenny Holden from FHI 360 Cambodia office to share some highlights about a very innovative Plus approach project that they have going on in Cambodia. And then we'll hear from two USAID country offices, Robin Martz in Cambodia and Shanta Gurung and Naramaya Limbu in Nepal, to give an overview of their integrated aspects of their country portfolios. These speakers experts in different slices of the topic, and I hope that in the end after the presentations we'll have painted a nice broad big picture for you. But one of the primary objectives of this webinar was to provide a platform to also hear your expertise. So I know that there's lots of people on the phone who also have lessons to share with the larger group. So I'm hoping that we can reserve a good chunk of time at the end to really have an interactive and meaningful discussion. So because of that, I'm going to keep the time fairly aggressively, and I apologize beforehand for that. So I'll just take the opportunity to turn it over to Marta Levitt, who is Senior Multi-Sector Advisor in the USAID Office of HIV/AIDS, to provide with our official welcome and opening remarks. Marta?
Hello, everyone. This is Marta Levitt from Washington. So I just thought I would go over quickly a USAID perspective, and I would even say the PEPFAR perspective, on family planning and HIV integration, looking from a more of an Asia perspective and a concentrated epidemic. The next slide. So I think that we are in a new era of the whole area of HIV and AIDS. There have been a number of high-level speeches, cables, and presentations that are done on our current priorities. President Obama had a memo on achieving an AIDS-free generation in January of this year. Also, there were remarks on the World AIDS Day, the most recent one, and then our Secretary of State, Hillary Clinton, had made remarks on creating an AIDS-free generation November 8th of 2011. These speeches really are guiding the priorities as we see them today. Next slide. And that we are It's a very exciting time. We've done a lot. We are beginning to see it's the beginning of the end, and there's this air of tremendous hope, the beginning of an end, getting to zero, an AIDS-free generation. This kind of dialogue that we're hearing, the kind of language we're hearing, is really quite exciting. So as President Obama said on World AIDS Day, there's an unwavering belief that we can and we will beat this disease. So it is a very different time. We have very new priorities now. And so this is a historic opportunity for an AIDS-free generation where we believe that no child should be born with the virus and that we can really reduce the risk of becoming infected for those who are particularly at risk. When people do become infected, they will have access to treatment. So all these, I think, are guiding ideas that very much influence integration of family planning and HIV work. Next. So some of the key messages we've been hearing is that an investment in the future is a smart investment. This investment should include efficiency of cost, do more with less, focus on impact, evidence-based interventions, make strategic allocation decisions and reduction of less effective activities, evaluate our programs, and cone and led responses. And all these small investments also equal to smart integration. We must think of integration in a smart way according to these principles. Next. So we need to do more with less. And related to integration and looking at HIV and family planning in particular, two things jumped out at me. One was that focus resources on high-impact evidence-based interventions, especially around the area of combination prevention with wide availability of condoms. So we've now promised 1 billion condoms over the next 2 years with a refocus on at-risk populations. The whole efficiencies, the one-stop clinic with basic services while driving down costs and driving up impact and saving more lives. So both of these are very much relevant to our discussion today. So that's a highlight of the efficiencies. Go on. So a core principle for family planning HIV integration was really highlighted in the guidance for this year's planning exercise. And just to summarize some of those principles, first of all, family planning HIV integration. Family planning principles of volunteerism, reproductive rights, regardless of HIV status, hold. So whatever we do, we have to hold on to those principles that we have done related to reproductive rights. And ARVs for an HIV-positive person should never be conditioned on that person's choice to accept or reject any other service, including family planning. And then finally, that we must prioritize opportunities for family planning funded HIV activity or PEPFAR funded HIV activities with reproductive health and family planning. Family planning activities, except for the purchase of commodities, can come from the same funding source, but also these opportunities to link our different programs together. So integration opportunities in concentrated epidemics that PEPFAR has recognized, not limited to this, but are the areas that they have highlighted in our guidance so far. Counseling for linkages. So the linkages to family planning programs for women, men, and HIV/AIDS prevention, care, and treatment programs, ideally at the same site. Integrating family planning services and PEPFAR-funded CMPCT and HIV care and treatment programs. Only commodities require separate funding. To be able to integrate family planning to other kinds of family planning services into the site with PEPFAR funding. So we just didn't want to confuse that. But the idea is to integrate family planning into CMPCT and care and treatment. HIV prevention messaging, if you can go back. Yes, HIV prevention messaging and support as well as HIV counseling and testing MCH and family planning for both men and women, and referrals for PMTCP and appropriate care and treatment for women who test HIV positive in any of the venues. And really monitoring enrollment and receipt of services when referrals are made to capture those linkages and ensure uptake of the services. Consumer principles for integrating family plan and HIV. And I think that's really an important one. We often have referrals that we're really sure how effective the referrals are. So the question, is HIV integration effective? There are two really areas. One is that I'd like to think about dual use of condoms plus another contraceptive, and hopefully today we'll hear about a successful approach. But generally, most of our evidence has not been as good as we'd like it to be after all of the decades of trying to have dual use condoms plus another contraceptive. However, I think that we do see islands of success, and maybe we can learn from those. A Cochrane systematic review looked at the effectiveness of integrating HIV services with MNCH and family planning services. And basically what it found, looking at a number of studies that were rigorous, we were able to find maybe about 20 studies out of many, but that integration is feasible and effective across a variety of integration model settings and populations. And other studies that measured health behavior all reported increased contraceptive use. So we are seeing some very positive results. And 3 studies actually measured changes in health status, such as percentage of unplanned pregnancy. But here's a call for rigorous design studies with direct comparisons of integrated versus non-integrated services, cost and cost effectiveness of integration services, and health outcomes such as HIV and STI incidence, morbidity, and mortality. We must do better studies to see how the real outcomes of integration. Thank you. So basically, one size really doesn't fit all. Family planning HIV integration has to be contextualized. I'm sure all of you know that. In Africa, or in places where we have generalized epidemics, we have high proportions of women of reproductive age who are HIV positive and on ART. Some of the countries I worked in Zambia, we have 350,000 people on ART. There's high fertility in these areas with increasing trends. We're seeing fertility and PEPFAR going up in these countries as people get on ART and regain their health and their fertility. We're also seeing low overall CPR and unmet need for family planning, and use in the general population is very low. Integration, we see HIV within family planning and MCH services and vice versa. But in concentrated epidemics is a very different situation and context, and we have to be, I think, smart in terms of our integration. HIV prevalence centered in very key populations, as you all know. They have comparatively lower total fertility rates. CPRs range from moderate to high, and use is quite high amongst most Mark done a very good job. I was very impressed when I visited Cambodia. And unintended pregnancy and abortion among female most at-risk populations is quite common. And people Can you hear me? Hello? Can you hear me?
Okay, that's better.
Oh, we're done? Okay, great. And then people with HIV/AIDS who are on ART may desire additional children. They might be ready to start their family or continue their family. So the whole integration, what makes sense needs to be contextualized, and we have to decide what is cost effective and what is the best way to integrate. So thank you very much.
Much, Martha. That side of yours is particularly compelling, I think, to really highlight. It's not just regional differences or epidemic differences, but it's a combination of both. And so I'll take the opportunity to move along through the agenda. I am up next to just walk us through a couple of slides that share more information about what we actually know right now about family planning for key populations in Asia. Of course, the first point that I like to make in any discussion or presentation related to family planning, regardless of age or not, is that all women have the right to determine the number and timing of their pregnancy and to safely achieve their fertility intentions, whether or not that means having a baby or preventing a pregnancy. But for women living with HIV who do not wish to become pregnant, family planning is not only their right, but it also offers the added benefit of preventing mother-to-child transmission of HIV. Indeed, we know that prevention of unintended pregnancies is acknowledged globally as a key element of any comprehensive PMTCT program. As such, it's only fitting that currently the global policy support for stronger linkages between the family planning and HIV fields is better than ever. At the very highest level, we have statements and policies from the most influential HIV leaders, donors, and institutions, including UNAIDS, PEPFAR, and the Global Fund, proclaiming that family planning is critical to the fight against HIV. Research on how to achieve these linkages continues to advance as well. We have expanding evidence-based, including modeling, behavioral, biomedical, and operations research data regarding how the family planning and HIV fields intersect. While more research is certainly needed, we know now more than ever about cost effectiveness, unmet need, the safety of methods for people living with HIV, and then to some degree the impact of integrating services. In part because of this global momentum from policymakers and donors and researchers, national level initiatives to strengthen the linkages between family planning and HIV are continuing to emerge. If you look at this map, a mere 9 years ago, Kenya was the first country in Africa with a government that committed to proactively linking family planning and HIV within its health system. But if fast forward to today, many more countries are following suit in the region. More countries highlighted here only reflect the concrete movement at highest government level, and there are many other research studies or pilot projects being implemented throughout the region in some of those other countries. But, and I think this is kind of a big but, most of the advocacy programs and research on the integration of family planning and HIV have remained focused on Africa. So while there are indeed some important lessons for advancing integration that we can draw from Africa, the concentrated nature of the epidemic and some of the reasons that Marta pointed out in that last slide necessitates strategies tailored to unique circumstances of Asia. So the bottom line really is that despite the similarities or differences, women in Asia affected by HIV suffer from lack of access to family planning services, and we know that they do experience disproportionate high rates of unintended pregnancy and abortion. So the majority of data that we have on these things really comes from female sex workers and then to a lesser degree, women and couples living with HIV. I think that makes Asia stand out are really the successful condom promotion programs. Substantial investments over the past decade have been made in condom promotion, other HIV prevention, and risk reduction programs, and they've to some degree been successful in improving consistent condom use, particularly among key populations. However, the attention paid particularly to the potential for prevention of unintended pregnancy through condom use has largely been absent from these effective campaigns, which typically miss the opportunity to address the broader SRH needs of women. And for instance, we can see that these are missed opportunities indeed. Despite widespread report of high condom use, women at risk for or living with HIV still have poorer reproductive health outcomes than the overall population. For example, the unmet need for family planning among female sex workers in many countries is significantly higher than the national average, as are the annual or lifetime rates of abortion. Living with HIV are also experiencing very high rates of unintended pregnancies, sometimes repeatedly in the case. Even with regular condom use to prevent STI or HIV infection, women who do not wish to become pregnant are in need of more reliable and effective contraceptive methods. So the need is there. Why are we not doing a better job at addressing these needs? I think challenges converge to make this difficult. In some countries, we have outdated policies about who can access family planning and which methods. Vertically oriented STI and HIV programs that do a good job of reaching at-risk women, but are typically narrowly focused and do not encompass broader reproductive health or family planning needs. The potential dual protection of condoms is often not realized by women in these groups. So, for example, with sex workers, condom use is much less frequent with their regular partners. Yet at the same time, dual method use of condom plus another family plan method has been difficult to promote and scale up. First, there's widespread discrimination of many populations in not only the legal but also the health system. And finally, even though I think to some degree we know what some of the needs are, right now we really lack the evidence that is specific to Asia about what women actually want with regard to family planning, things like what types of methods they prefer and where to receive services, and moreover, evaluations of integrated program models and what works are currently lacking. So on that note, I'm going to stop and keep our agenda moving along. I'll take the opportunity here just to make another quick note that if you do have questions that you'd like for clarification, please just enter them through the chat function and we'll begin to address them when everyone is finished speaking. So I will take this opportunity to turn it over to Susan Paxton, an internationally renowned HIV advocate and currently an advisor to the Asia Pacific Network of People Living with HIV. And she's given us some more information about her perspective on the reproductive health experiences and needs of the community of women living positively with HIV in India. So Susan, I have you on the line.
Can you hear me?
Can.
Good. I'll go ahead. For those listening, I'm a woman who's been living with HIV for over 20 years, and I'm a mother. But I'm really talking from the perspective of my work in Asia with women living with HIV, and particularly some of the findings from a study that the Asia Pacific Network of People with HIV did last year, which was among these 6 countries that you can see, 3 in South Asia, Bangladesh, India, and Nepal, and 3 Southeast Asia, Cambodia, Indonesia, and Vietnam. And it was a robust study. It was a very long questionnaire that was administered face-to-face with over 750 women. We did focus group discussions. We did interviews. And we chose women who had been pregnant in the past 18 months. And do Google positive and pregnant, how dare you, and you'll certainly be able to find the full report. In the study, I mean, we did, yes, integration is important, but I think we need to just sort of take a step back and I know the first, when the topic was being introduced, we talked about voluntary counselling. In this particular study, in India, 75% of the respondents had been tested during their pregnancy, and only half of them got pre-test counselling, which I find really shocking. We talked to women about their pregnancies, but we did talk about family planning. Can we have the next slide, please? The thing is that amongst women living with HIV, they say condoms are the only contraception that's promoted amongst them. And no, in Asia, the majority of women really, the majority do have sex with their husband only. They're not likely to be passing HIV on to others on the whole. And these women are predominantly married women, 77% of them are married women, and many of them are saying we can't make our husbands use condoms. We don't want the pregnancy. Our husbands want us to be pregnant. They don't enjoy using condoms. So it's all the same things that are, women without HIV or untested, they face the same issues on condom use. It's basically they have no control. And we do have high percentage of women saying that the pregnancy was unwanted, and I'm not looking at unintended, but unwanted, and that women are saying they want methods that they can control, IUDs, pills, injectables, female condoms. Women in Vietnam talked about female condoms and how they would like to get access to them. We know that female condoms have not been widely promoted in Asia. And what this means is that we are getting very high rates of abortions. A whole study, it was 1 in 5 women had an abortion. Many of these women are women who said, well, I did want the pregnancy, but then I was tested during the pregnancy and I was told that my baby would be born positive. There's a lot of misinformation out there. And so many of the wanted pregnancies were aborted, and of course many of the unwanted pregnancies. And it got to over, it was like 44% of pregnancies in Vietnam were aborted. If we go next slide, and I think this is probably at the heart of it, is the discrimination women face in the health sector. We have this quote by one woman in Vietnam who, when she went to the obstetrics and gynecology department, nurses said to her, "How dare you have a baby? Aren't you afraid to die?" And then the doctor said, "You're already positive, so your health is not good, so you should have an abortion." And the woman, he gave me many reasons why I should not continue with the pregnancy. I said, "I have a right to have a baby under the law." But this young woman was quite strong, and many women are coerced into abortions. And I think really key problem is that women are facing discrimination within the maternal health sector. They're not facing it any longer within the HIV sector because HIV doctors understand that women are at low level of infecting others if they're on ARVs, and the HIV doctors understand the possibility that women are going to have could have a long, healthy life. But these positive women are choosing to get pregnant, and now being the maternal health sector is suddenly facing, women with HIV getting pregnant. It's fear. They're not, and of course integration would help this. They're afraid of, they don't know the WHO guidelines. They don't realize that women can have safe, healthy, normal vaginal deliveries. They don't understand what the latest medical information is. And if we have the next slide. Thank you. And when women do, the one before, yes, women do deliver. I mean, this is just one short quote. And there are many sad ones in the report. During delivery, the doctor wanted to put on 2 sets of gloves. He put on 1 set, but the baby was already coming out, and the doctor tried to push it back in so he could get on another set of gloves. And we've got many stories in the report of women who are totally abandoned during delivery, and one woman gave birth to twins, and she was up on stirrups, and nobody was in the room, and the 2 babies died. And because there's this discrimination in the maternal health sector, what we find is that many women are actually avoiding healthcare altogether during their pregnancy. Women might know their HIV status, or afraid of it, and they know that they're going to be tested and not, and they're going to face this discrimination. They simply avoid the health care, and so they miss out completely. So I go to my last slide. Some that didn't go into the report, but I've really only been looking into these cases, these mentor mothers recently. It's brilliant. Mentor mothers are being used in many places in Africa by different organizations. We're training HIV-positive women to be involved, so it's community engagement in the health facility. because the health facility cannot do it alone. And these mentor mothers have had amazing success at getting women to be engaged, getting follow-up, giving them appropriate information and support. We have to increase the range of contraceptives available and let women know what contraceptives they can use safely. And I think engagement of men, and there are good promising practices that the UNAIDS have documented on engaging men to be more involved. So it's not just the woman being diagnosed during the pregnancy. She goes home, she's the first one to bring HIV into the family, therefore, or to be, this is perceived, and she's the one that faces discrimination, often thrown out from the home, and the whole quality of life in her and her children is destroyed. So we need to engage men in the whole process as well, and we have to improve sensitivity of the maternal health workers about the sexual and reproductive health rights of women living with HIV. So they're not it does border on paranoia, the fear maternal health workers have, and they need to be brought up. And I believe women living with HIV are the ones that can do the training of maternal health care workers in realizing that it's safe to have them as clients, and the engagement with other HIV-positive women or women coming to antenatal clinics for pregnancy testing. So I think I'll stop there. Thank you.
Thank you so much, Susan. I think that your presentation highlights so well the real violations of women's reproductive rights that happen. And when I read your report, Positive and Pregnant, it just sheds so much light on the different ways that discrimination manifests itself, either for women who would like to get pregnant and are told they're not allowed to, for women who are currently pregnant and are discriminated against by their gynecologist or the person meant to deliver the baby, or the women who are not necessarily interested in getting pregnant but aren't given counsel in any methods because they're presumed to not be sexually active. So I encourage everyone attending to go online and access Susan's report because it's very compelling. So thank you, Susan. I will move the agenda along by introducing now Jenny Holden, who is the Technical Program Officer in FHI 360's Cambia office. We know that many women at risk for HIV in Asia, such as female sex workers, do have unmet need for family planning, which is evident by continued high rates of unintended pregnancies and abortions, even with high condom use, mentioned by a couple of the presenters so far. But I think we all know well the real challenges behind getting clients to understand the benefits of using both a condom and another method of family planning. So just going to help us by shedding some light on a very innovative strategy for doing just that. So Jenny, I'll turn it over to you.
Hi there, good morning, good evening, those in America. I'm just going to talk about FHI 360 Cambodia's Condom Plus approach to promoting dual method use among female sex workers, or as they're known in Cambodia, entertainment workers. So first, promoting dual method use for entertainment workers. Well, in Cambodia, as Trish mentioned, entertainment workers have very high rates of unintended pregnancy and abortions. A recent study among 600 entertainment workers found that over a quarter had an abortion in the past year, and that's despite almost 100% reporting consistent condom use with their last client. Use is high in Cambodia among entertainment workers with their commercial or paying clients, but it's lower with their non-commercial partners, known as sweethearts, because very low rates of hormonal contraceptive use, especially when compared to the general population. Condoms, which are highly effective in preventing STIs and HIV transmission, are effective in hormonal contraceptives in preventing pregnancy, both in TIF and PEPFAR use. Workers are at risk for both unintended pregnancy and HIV and STIs. It's recommended that such women be counselled to use two forms of protection, one to prevent STI and one to prevent HIV and STI infection. So Several changes to promoting dual method use in Cambodia. Many entertainment workers believe that condom alone is enough, which is perhaps not surprising, as until recently condoms were the only dual protection method being promoted amongst this group. As it's simply being convenient and effective, women view condoms as being a healthy option that don't have any harmful side effects, unlike other methods. There are many misconceptions in Cambodia. For example, people believe that with the implant it can break in your arm, or you can't lift heavy things, or the egg can move around your body. Entertainment workers often face stigma and discrimination when they visit the healthcare providers. And they're being told that condoms are enough for them. Family planning messages and services in Cambodia are focused very much on married couples. Widespread cultural belief here among entertainment workers and also healthcare providers that other contraceptive methods are not suitable for entertainment workers who are single. And actually, during our research of this project and pre-testing, it was really evident that the terms family planning and birth spacing resonate with entertainment workers. They don't think that they're relevant for them, but they are concerned with pregnancy prevention. So we have to be very careful with the language that we use with this group. Next slide. From USAID, FHA 360 within the PRESIT project is pilot integrating family planning services into existing HIV prevention services for entertainment workers. The program is to reduce the rate of unintended pregnancy and abortion among entertainment workers. And the strategic objective and main program outcome is to increase informed choice uptake of condom plus another contraceptive method among entertainment workers. The project will deliver results in 3 areas relating to demand, access, and quality of integrated services. So our FHI 360's Smart Girl program is well positioned to reach entertainment workers with family planning information and services. The SMAM, for those of you that don't know, it was launched in 2009 to prevent and mitigate the impacts of HIV among entertainment workers. There are currently 11 Smart Girl sites or drop-in centres in Cambodia, reaching over 15,000 entertainment workers. So we see these drop-in centres in 3 provinces and a number of criteria. And under our model, entertainment workers are given increased access to information on family planning, either at their place of work, so it might be a restaurant, karaoke bar, or massage parlour, or drop into their local Smart Girl club. The propitiated model we've developed was influenced by a project in Zambia, where having a dedicated family planning provider in health facilities able to talk to women about informed choice before their consultation with a doctor actually increased an uptake of contraception, particularly long-acting methods. We have hired a trained provider, a midwife, who's experienced in providing planning services to high-risk groups for each of the 3 drop-in centres. The providers provide family planning screening, counselling, and also group information sessions. And they're the entertainment workers to partner family planning clinics. In addition, there accompanies outreach teams to places where entertainers work to conduct group information sessions on them plus another family planning method, and also to screen entertainment workers for family planning needs. For it to be effective, it's really important that a strong referral system is in place. So each site has been strengthening relationships with partner clinics and helping to address stigma and discrimination by acting as a bridge between the partner clinics and clients. An essential part of our model is to advocate for the lowest price family planning services for our clients to reduce or hopefully eradicate financial barriers towards uptake. 3 pilot provinces, we've actually been successful in developing an OU with a local provider to provide free-of-charge family planning methods for clients referred from the Smart Girl program. We've developed some strategic behaviour change communication tools to support our condom strategy. Income, I think I mentioned before, but SBC materials focusing on family planning as used with the general population often reinforce cultural perceptions that family planning is for married couples only. So we felt that we needed to create some new materials for this group. So we developed an innovative concept for these materials promoting Condom Plus for entities. The concept involves 5 smart girls, 5 Condom Plus smart girls, who use Condom Plus a different family planning method. 5 girls challenge many of the myths and misconceptions surrounding family planning. For example, they're all single, challenges the common idea that women must be married or in a relationship to use contraception. Nancy programmers and policymakers and programmers have expressed concerns about risk compensation in the form of reduced condom use as a result of dual method promotion. All our Condom Plus materials and during all our interactions with entertainment workers, we stress that contraceptive methods must be used alongside condoms, as these are the only methods that can prevent against HIV and STI infection. So the pilot is actually in its initial stages, so we haven't measured our key indicators yet, but we'll be continuing to monitor and report on the impact of our integrated service. But the results have been quite promising for the first month, and showing that with informed choice counselling and screening and reduced cost of commodities, many entertainment workers are actually taking up another contraceptive method in addition to condoms. So yeah, to finish this presentation by giving you an example of one of the women that we're reaching. Co. She is 28 years old and she works as an entertainment worker in a restaurant outside Phnom Penh. Co had never used any method of contraception except for condoms, which she finds hard to always use, especially with her sweetheart. She has had 5 abortions in the past, and she's one of many entertainment workers who are benefiting from access to information and referrals of planning through our program. So Co met with the Smart Girl provider during each session at her restaurant. She was family planning need and had the opportunity to have a free one-to-one family planning counselling session where the provider through each method discuss the advantages and side effects of each method, and also emphasise the importance of always using a condom. Last month she actually went to be fitted with the implant, so you're going to be protected from unintended pregnancy for up to 5 years. Met with her earlier this week, and she told me that before she'd had family planning counselling through Smart Girl, she had heard of implant and she'd heard of all the family planning methods, but she was scared of them. She feared that they would be painful, they would have really negative side effects. But after speaking to her, she felt confident that actually that this isn't the case and that they were healthy and safe and effective. She also, as a result of the program, felt more confident to talk to her sweetheart about the importance of always using a condom. So yeah, we hope that we'll reach much more women like Co through this program. So that's the end of my presentation. Thanks very much for listening.
Jenny, that was a really nice presentation. For everyone listening, had the opportunity to go visit Smart Girl in person about 2 months ago, and it really is a great program where I think the clients and the girls and young women feel really comfortable there, and are really grateful for the wide array of services that they do access to through Smart Girl. So, Jenny, thank you for sharing that. So I think now we've heard a few different angles about the pressing need for keep options with services. So I'd like to just do a quick check on time. We have 90 minutes scheduled for the webinar. We are at the 60-minute mark. So I have time to conclude with our last 2 speakers, who are both from USAID, respectively Cambodia and Nepal, who are going to share with us a little bit about how their missions are supporting efforts in countries to advance integration And I would like to reserve at least 15 minutes at the end where we can hear from some of the other folks on the line with either questions or comments for discussion. So with further delay, I will try to transfer to Robin. Robin, do we still have you on the line?
And can you hear me okay?
Yes, we can. Go right ahead.
Thanks a lot, Tricia, and thanks, Marta, for the great intro, and Susan, a very interesting presentation, and a great big thanks to Jenny, who's here in Cambodia with us, who gave an excellent overview of FHI 360 activities that are supported by USAID Cambodia. So because Jenny did such an excellent job talking about FHI 360's activities, I'm going to focus on another project that USAID Cambodia supports, the SIFPO project. So SIFPO stands for Support for International Family Planning Organizations, and it's between and Stokes UK. It's a 5-year agreement that's begun in 2010. And partners include Population Council, ICRW, Engender Health, and International HIV/AIDS Alliance. And so USAID Cambodia bought into this larger agreement, and we support Marie Stokes International Cambodia for certain activities. So you can see the objectives of the SIFPO project here in Cambodia. I'm going to read this because I know we're kind of short on time, but just highlighting on the first one, there's a focus on long-acting and permanent methods. And Marie Stokes Cambodia works in 2 provinces here in Cambodia. And the second objective, and I'll actually get into this a little bit more later, this is a really important aspect of this project, which includes piloting integrated and innovative approaches to integrating sexual reproductive health and HIV/AIDS activities. And so, again, I'll talk about that a little bit more later. And in terms of 3 and 4, this is focusing on strengthening the demand side health financing mechanisms. And so, for example, Marie Stokes is using reproductive health vouchers. An objective that's held in the large agreement between MSI UK and USAID Washington, and that's to include the strengthening of MSI's organizational and technical capacity at the country level. So in terms of our support to Marie Stokes here in the SIFPO project, we support them with population funds, family planning funding, and that supports some of the things that I've just mentioned in terms of increasing access to a full range of family planning methods, with particular attention to long-acting and permanent methods. And we also support them with our PEPFAR and our HIV monies. And so we hope to have them pilot some effective ways of integrating family planning into HIV prevention and treatment services. So to give you kind of a quick look at some of the objectives of SIFPO. I'm not going to spend a lot of time, but as I said, because we support them with both POP money and PEPFAR money, this is some of the objectives in terms of the straight family planning support that Marie Stokes provides. And I'm not going to go into a lot of detail. We'll just go on right to the next one so we can look at some of the FP-HIV integration activities that Marie Stokes is carrying out. Thanks. So in terms of these FP-HIV integration activities, so Marie Stokes has already trained nearly 100 HIV service providers in terms of providing comprehensive family planning services at very specific HIV sites. What they've done is working very closely with both national programs, so the National Maternal Child Health Center, NMCHC, as well as NCHADS, which is National Center for HIV/AIDS, Dermatology, and STDs. So working closely with both centers, they've modified slightly a family planning curriculum and provided this training to HIV service providers. The second piece, which is extremely important, especially as we're being in front in Cambodia, but also having a ways to go in terms of the best ways to provide family planning services to both most at-risk populations and PLHIV. We've got strong commitment by both sides in terms of government support, but it's trying to figure out the best way forward. So one of the things that we asked Marie Stokes to do was to work closely with both sides, work closely with the government, and our idea was that they would help create a vision or assist the government in either developing new or revising existing SOPs or standing operating procedures that reflect a more impactful and cost-effective approach to increase availability of quality family planning services for both PHIV and MARPs. So in order to that, we decided that the best way forward was to start with an assessment to look and see what is the current status of FP-HIV integration efforts in Cambodia. This assessment actually was just completed last week, so it's very, very new, and this is just kind of a very quick overview of some of the preliminary findings. But a 2-week assessment, and it was led by an internationally renowned expert in the field, and included participation from not only all of our USAID implementing partners here in Cambodia, but also U.S. Centers for Disease Control, the National HIV/AIDS Alliance, representatives from PLHIV and MARPs community groups, and as well as government participants that participated in the assessment. So from both centers, the NCHSP and HIV side. At the end of the 2-week assessment, a visioning workshop was held to share the preliminary findings from the assessment and also do some brainstorming around how best to move forward with this information. So again, you can see up on the slide the some sort of high-level issues in terms of some of the preliminary findings. So into the current status of integration efforts, as I said before, there is strong support within the government of Cambodia in terms of integration efforts, and Cambodia has been a leader in terms of HIV prevention as well as care and treatment, and so it continues to be a leader in the area as well. And both sides are really willing to review and look at any sort of emerging lessons. I mean, we've talked about, I heard a comment, I think, from Tricia that, there's just really a paucity of data and evidence out there. But Cambodia is great in terms of willing to, and fairly quick to respond in terms of new best practices and new evidence that comes out, revise their existing SOPs. Let's see. In terms of leadership and capacity, just quickly, again, leadership is evident on both the HIV and the family planning sides, but there is technical assistance and collaboration required related to a variety of areas, including all aspects of provider counseling, both on both sides of the coin in terms of family planning providers as well as HIV providers, training and ongoing supervision of staff, providing the counseling, referral and follow-up with clients, understanding of what some of the barriers are to men and women accessing these services and uptake of family planning services, and joint reporting and monitoring and evaluation, as well as the logistics. So these were some of the areas that really needed to be looked into further. The assessment team found that while there have been some improvements, there's still much stigma surrounding not only sex work, but anything related to premarital sex. The commodities, the availability of a full range of methods is a problem in Cambodia. It's not just for MARPs and PLHIV, but at health centers. There's not usually a full range of methods, and there's no real uptake of any long-acting or permanent methods. And some of the hiccups in terms of these early stages of integration is there's been issues with commodities, family planning commodities, to the HIV sites. In terms of strategic directions, of course, Cambodia is a concentrated epidemic, and so our prevention efforts are focused on MARPs and entertainment workers and MSM and IDU. And so it doesn't necessarily make sense to integrate, HIV services into the larger family planning service delivery system. However, family planning into HIV is probably only feasible, but something that needs to be looked into in terms of the most cost-effective, impactful models. And not be, a one-stop shop. I think that was from President Obama's comments from World AIDS Day that, looking for sort of this one-stop shop for this type services, which I think, could be ill, but may not be the most cost-effective way. So thinking about how important these referral linkages are and ensuring that people are getting the services they need and being able to follow people, whether that's through some sort of unique identifier code or system or some other system. And the needs for joint reporting and monitoring, because you're working sort of across two different centers, both HIV and SP. So sorry for flying through that, but I think that there needs to be some time for question and answers, and I guess there's another speaker. So I will finish there and sign, obviously, and thanks for listening.
Thanks, Robin. That was great. And in the interest of time, I will save my own comments to the end as well and move us along to our colleagues from Nepal. And I think we have a sort of group effort there, so I'm actually not going to presume that I know who is going to be the first speaker. So I will, if possible, turn over to you all, and you can introduce yourselves as you go along. Do we have colleagues from Nepal on the line? Okay, great.
Yes. Arsha, can you hear us?
I can. That sounds like Han. Is that you?
That is me. So first of all, thanks to you and our colleagues from the U.S. government and other implementing partners for convening this really important webinar. And unfortunately, my colleagues Shanta and Naramaya cannot be here today because Shanta is on a field trip with Dr. Paul Farmer, who's here in Nepal, and she's actually going to be showing him our FP-HIV integration activities in this field. And my colleague Naramaya, he's actually meeting with our government counterparts right now to talk about this issue. So it's a really important issue for us. Mm-hmm. I am here. I'm the Deputy Director for Health and Family Planning here at USAID Nepal. And I'm here with my colleagues Gajendra and Shola, and they are our focal points for both family planning and maternal health. So we will do a brisk walk through these slides about our work in family planning HIV. So a lot of this is carried out through our SAT project. This is a cooperative agreement that USAID signed with FHI 360. And SAT means together in Nepali, which reflects in terms of our partnership between us and FHI 360 and also the government of Nepal, but also our intent to really integrate HIV and family planning. So USAID has been evaluating 61 years of development partnerships in Nepal, and we're very proud of the fact that we were the ones who jump-started the HIV/AIDS response in Nepal. And in the design of our HIV programs, as well as our other health programs, we certainly embrace the principles of strategic coordination integration that's reflected in the President's Global Health Initiative, as well as the government of Nepal's other strategic documents. Please. All right. In the SAT project, there are 5 major outcome areas. And the first one, I should say the second outcome is the one that's focused on the integration of HIV and family planning. And this is really grounded in 3 principles. The first being rights, in terms of making sure that regardless of your status, whether you're living with or you're affected by HIV, that you have a right to all pregnancy options. And the second principle would be universal access, which emanates from sort of the operationalizing that rights-based approach, and that we want to make sure that we expand the coverage of family planning products and services across the country and in all populations. The third principle is quality. Ensure that as we scale up family HIV in an integrated way, that we address and we tailor the interventions based on the specific needs in our populations. And for SAT, this project will cover female sex workers, people living with HIV, as well as migrant populations. And we know that the needs to tailor the counseling and the services that are provided to these populations to make sure they make the proper decisions for themselves in terms of which family planning methods they want to use. So next 2 slides will really sort of just outline some of the major interventions that we are going to support through that second outcome area. And so in terms of trying to increase the use of family planning services among the most at-risk populations, certainly one of the things that we'd like to do is to strengthen the integration of family planning into existing counseling and services that are provided in settings for HIV prevention, care, and treatment. So we want to integrate family planning messages into the counseling, and we also want to make sure that family planning interventions are also present in the other intervention points, such as prevention of mother-to-child transmission, as well as antiretroviral treatment and care. Next. In addition to counseling and services, we'd also like to integrate family planning in our health promotion and migrant health efforts. And so by doing that, we want to make sure that family planning messages are certainly part of the counseling as well as behavioral change communication campaigns. And certainly saw that with SHI 360's work in Cambodia, doing work with entertainment workers, for example, and I think those are some of the interventions that we would like to adopt here in Nepal. And then certainly in terms of integrating family planning into migrant health. Now, what's interesting in terms of Nepal's trends is that even though total fertility rate, this is based on the 2011 Demographic and Health Survey, that even though total fertility rate has declined, the contraceptive prevalence rate has remained stagnant, and we think it's because of the increase in migration and the fact that this particular subgroup is not, that there's a high level of unmet need for them. And so we want to make that we're not seeing any opportunities in terms of intervening for this group with a combined package of both HIV and family planning services. And okay, final slide. Now, we talk about sort of integration at the service delivery level, and we certainly want to promote integration at the national level as well. Typically, family planning and HIV have been construed as vertical programs. And as part of this integration, and in terms of the advocacy and our engagement and dialogue with the government, we want to make sure that we do this in a way where we strengthen the health system and we really integrate these 2 vertical programs and such actually create a more horizontal or a diagonal health system that is capable of taking on and delivering integrated services. Now, our first really next step in doing this is that we're going to have a national consensus building workshop with both the Family Health Division, which oversees the National Family Planning Program, as well as the National Center for AIDS and STI Control. And in that workshop, we're going to talk about 3 main issues in terms of what are the types and areas for service integration, the extent of the integration that needs to happen, and then what are some of the steps that we need to really establish, monitor, and sustain a high-quality delivery of integrated services. And so one of the things that we'll talk about in that is, for example, in the setup of a surveillance system or the improvement of the current surveillance system to ensure that, for example, in, let's say, female sex workers, that even though we are promoting a range of family planning options for them, they are, let's say, using condoms for the dual protection for both HIV prevention and also for unintended pregnancies. So final slide, and again, thanks so much for convening this webinar, and we are very keen to learn about similar kinds of activities from our colleagues in other countries.
Thank you so much, Han. That was really interesting. Again, just personally, I got to see the SAS project about 2 months ago, and they're doing really great work. And I think that's a nice note to close on, is that, you know, part of the spirit of this event is to learn from one another and to share their experiences and sort of see what is similar and what's different, and what lessons can we take from one another to apply to programs elsewhere. So I want to thank all of our speakers for really being forthcoming about your knowledge and your experiences, and, you know, painting not only the big picture of what's been happening globally with regard to, you know, the contraceptive needs of women and couples affected by HIV, but also delving down deeper into some of the, you know, more prickly issues and challenges that we experience in trying to meet some of those needs. And also, you know, on the other side, especially with Jenny, kind of the promising practices that are emerging. So I'd like to take the opportunity to open it up and allow attendees, speakers, or to just comments or things for discussion from your own experiences. You either use the chat function that's in the right sidebar of your screen, or I believe, and Josh, you can correct me, that you push *1 and on the phone, and you can enter it into the audio to ask a question. So up for questions, and you may address it to a particular speaker, the group, or just share a comment.
Thank you. If you'd like to ask a question at this time, simply press *, then the number 1 on your telephone keypad, and that will cue our operator to bring you into the call. And you can also continue to ask web questions at this time. Please find the chat window on the right-hand side of your screen and click Send to submit your question.
As a facilitator, I have posted some just general food for thought on the screen to leave up while we have the question and answer period. It's like some people are entering some questions. Before we come in, I might just use this chance before to ask Susan a question of my own, since I have the privilege of having the floor. So, Susan, are you still on the line?
Yes, I am.
Okay, great. You know, I really appreciated the point you made at the end of your presentation about the potential for having women with HIV themselves act as people who are sensitizing the healthcare providers to the the preferred service delivery mechanisms and attitudes and knowledge. And I think that that's a really important idea that in the global health community we often don't necessarily recognize as much. I think it's understood that we are to engage the communities of people we actually mean to serve, but that doesn't always happen. So I'm wondering if you have any examples of experiences where you know, Asia Pacific Network was given the opportunity to be engaged in a meaningful way like that.
Really, I can speak from my perspective in Australia as a positive speaker, because I'm involved in the Speakers Bureau. And I think there aren't many countries where HIV-positive speakers do train medical staff, but there are a couple of universities where we go in every year and do medical students. We talk to medical students, and always the response has been that this has been what has changed their attitudes. I mean, my PhD 12 years ago was about it indicated the significant impact of meeting and talking to people living with HIV, that lived experience. It is real, and now we're getting this evidence in Africa. I'm kind of sad not to have heard more of an engagement. I know in Cambodia, the Cambodian community of women it just has no sustainable funding. They're only working in a couple of provinces. I know throughout Cambodia there are self-help groups everywhere, and I know they are engaged in the MMMs or the Friends Help Friends centres at hospitals. But still we haven't got sustainability with the women living with HIV, engaging them as an integral part of the community engagement. And I honestly do feel it's the only way we're going to get any success. I mean, I just want to say the issue of single women is so important, and having women living with HIV talking about their experiences also to single women, because in Asia, single women have terrible challenges getting any family contraceptive advice and help. So yeah, look, I just hope that we can start to really engage women living with HIV in the response in a meaningful and effective way. And if you do, I mean, I just read this promising practices stuff from Africa here, and AIDS has published stories there of staying very, very big changes by engaging community members as workers and linkages with the health services. Thank you.
Yeah, no, thank you for that. I hear my colleagues in Cambodia particularly about the issue of the young single women who come to the Smart Girl program and don't necessarily feel like they are in a position to receive something called family planning because they don't necessarily have a family yet, and so they don't necessarily make that connection in their minds. But I appreciate your points being made about the potential impact that we can see from meaningful engagement, not the, sometimes so-called engagement that maybe someone would be invited to a meeting or meant to be invited to a working group, but necessarily helping steer the process, and I think it's critically important. So thank you for your perspective. One question about are there any evidence-based documents for the effectiveness of this Condom Plus, other contraceptives in HIV prevention and the prevention of unintended pregnancy? So I think that's a really popular question, one that we've been asking ourselves in the integration field for some time. And before I ask Jenny if she's still on the line to maybe chime in here with some of what they're doing FHI 360 program, I recently did a literature on programs that have been evaluated and published in the Asia region on this particular topic and more broad FP and HIV integration, and I really didn't come up with much. So I think where we're at right now is that programs are starting to try strategies to better promote dual method use, but I don't think we've yet gotten to the point where those efforts are being systematically documented, let alone evaluated and then published. So I think that, if some of the attendees out there listening are doing similar things, I'd just like to stress the importance of filling that gap by documenting what you're doing, including in, Nepal staff program, at the FHI 360 and other SI and other partner initiatives in Cambodia who are starting to these types of things. We need to document them and disseminate the lessons that we learn from them. Okay, I have one phone question from Julia. Julia, can you get us Julia?
Hello, can you hear me? Hi,
your line is open.
From UNS. It's Julie from UNFPA Asia Pacific Regional Office. First of all, to say terrific. Thank you so much for this webinar. It's been very, very useful. I wanted to just add some information about what we're doing through UNFPA country offices in the region, and also to just pick up a few of the points that have been raised. First of all, to say, yes, we're now in the process of working with a number of our country offices, about 7, to look at an integrated approach in our efforts to integrate family planning into sex worker HIV prevention programs in countries. Also looking at integrating sex reproductive health into HIV policy documents. So a number of countries, Indonesia and Myanmar, leap to mind. There's work going on for new guidelines on HIV, sexual transmission of HIV, preventing sexual transmission of HIV. I want to make sure that the incorporating SRH into those policy documents really strengthens the hand of what you're doing. Also to say that there is a significant program of integrating SRH in Myanmar. UNFPA country office works closely with top PSI there, and there's been a lot of efforts there. We're actually developing a detailed case study of the work of top PSI in Myanmar. So just to say that the other element is, because we're going to be doing this on in technical assistance on a multi-country basis, we're also going to design a operations research framework. So in each country we can be looking at how are we going as we go, and to document and be able to share, because I think the point that's made really well is that we don't have a strong enough evidence base to make the argument for better integration. So I think this is a really, really valuable forum for sharing the progress that you're all making, and I'd be happy to share the concept note of the countries we intend to work in, the operations framework and so on. So just to pick up a couple of points that have been made, I was interested, Jenny, in your comments about family planning language not necessarily resonating with entertainment workers in Cambodia, and the importance of looking at our language and pregnancy prevention language in particular. I guess my only reservation about that is focusing on the assumption that entertainment workers might not also be women choosing to have children. So trying to get that balance right in the way that we design our interventions that also ensure that we are linking women who may be entertainment workers to maternal child health contexts. And I think that picks Susan's point about we really need to be focused on how do we support communities' engagement with the design of these programs. So addressing HIV discrimination, stigma associated with sex work, as an integral part to ensuring how do we get positive and from HIV testing sites to maternal child health services and ensure the quality and the appropriate of those services in those contexts. And I think community engagement there is absolutely critical. Planning to do quite a bit of work in the design in each country, ensuring that the sex worker organisations we work with are actually involved in working with the service providers in MCH. So I think that really sort of picks up Susan's point. So I think the last point I wanted to make was Robin's point about what to integrate. I think what's part of the discussion so far is there seems to be a consensus that there's real value in putting family planning into HIV programming focused on sex workers. But I think the query is making sure that if we're improving access to testing in HIV prevention sites for sex workers, we're also saying, so when women test positive, how do we ensure if they choose to have a child, they're going to get access to maternal child health that's appropriate to their needs, and community engagement there is critical. So thanks very much. Just some comments.
All of your points are very well taken. I want to give the opportunity to any of the other presenters or attendees to respond. I take the privilege again. Anyone want to respond to what Julia has shared with us?
This is Susan. Can I just make one comment? Just because, I realise, that you are out there, you're funders and supporters of networks, and when you're looking at meaningful involvement of women, I know it's messy, but as well as the national networks of people with HIV, we have to include national networks of women. I know it's difficult because in some countries they've created separate and different national networks just for women, but they've done that for a reason, and they've done it because in the people living with HIV networks in most countries, they are dominated by men. There's more than 2 women ever on the board, and they're not meeting women's sexual and reproductive health needs. And so, I mean, we don't call it family planning, we just call it sexual reproductive health. But I think, messy as it is, you have to include both. I mean, because I'm thinking about countries like Cambodia or Myanmar, where they're very separate networks. You've got to involve the women. Thanks.
And Tran, if I could also make one point too, to sort of just contribute to this discussion. So this is actually really in response to the question that you posed up, as well as some of the contributions from our other folks so far. When we think about women, we really have to be careful in terms of doing proper gender analyses to identify which constituencies we're talking about and to develop tailored approaches. So I think, Susan, you mentioned in terms of women living with HIV, I think that's one really important one. And for us, I think what's also important is that we should think about and remember men, and I think it would be really good to think about how we deliver tailored FP HIV integration for men who have sex with men and women, as well as women who have sex with women and men. That, and then the other constituency in Nepal that that is quite sizable in number are the transgender population, in terms of especially male-female transgender people. Family planning and reproductive health interventions are important because by participating in these counseling sessions, they actually reinforce their identity as women, which is who they aspire to be. So it's really important to think about what are the different populations and what are different needs when we think about implementing FP-HIV integration activities.
Thank you. I think that sets me up for actually sharing a slide that Martha created, just to give us a sense of the rationale behind differentiating aspects of people that, for the purposes of being concise, we've lumped together as key populations or most at risk or people living with HIV and things like that. But I think that there are very important differences in these different clinics. As you can see on this slide, we have most populations pulled out from people living with HIV, but I think you bring up some other important groups like transgender, and one group that we haven't talked much at all about on this call are migrants. And I know it's a more big issue in some countries than others, but migrant men and women have very different sexual and reproductive health needs than the general population in most of the countries that they live in. So I think it's important to take these unique aspects of people as individuals and not just as characteristics, being a larger group when we're designing our programs, when we're designing our materials, when we're providing training to healthcare workers. It should really permeate just as the meaningful involvement and engagement of women in and throughout all of our activities. Do we have any questions coming in from anyone else? I don't see one waiting in the phone queue. I don't see anyone else in the chat line. So unless anyone wants to make last comment, I'll give you a minute to shout if you do, and otherwise we will begin to close out.
This is Martha. Can you hear me?
Oh, yes, go ahead.
Great. One group that we haven't really mentioned is youth. Many young people are engaging in risky behavior, so that hasn't come up at all. And they have both a need to protect themselves from HIV, STIs, as well as unintended pregnancies. So I know that's a whole other group. but they need youth-friendly services, etc. I think that we really do need to break down. I really appreciate what everyone's saying. Break down the populations that are in particular affected and all their unique needs and concerns. The other thing I didn't hear very much about, but when we were I happened to be in the assessment of Cambodia, and we heard some about people in ARVs and concerns about how the ARVs might affect the fetus and their pregnancy, and doctors saying it's probably better for you not to be pregnant. So those types of, we talked about misconceptions, but I don't know if we had mentioned that. So I think, really doctors and nurses and counselors all really need to have complete information themselves and understand the effects or non-effects of ART on pregnancy and the health of the woman. So that was just the last type of thing I wanted to say.
Now, this is Susan just responding. I think they're really important points because the doctors on the ground don't get up-to-date information. We know that WHO guidelines are constantly changing, and we came across situations where a woman was pregnant, was put on efavirenz. Another woman who was pregnant on efavirenz was encouraged to abort. We know that there are, I think it's about 29% of women in Cambodia still using stavudine. So I do think these are really important issues about how do we get up-to-date information to the people that are working at the grassroots level with clients.
Great to both of you so much for your closing remarks. Does anyone else have one last comment to make? I'm going to pull up what I think summarizes.
This is Robin. Can I just make one last comment?
Actually,
in response to Marta and Susan just mentioned about the misconceptions, I completely agree. I think that unfortunately here in Cambodia, it's not just limited to the most at-risk populations or PLHIV, but unfortunately in the general population, there's a lot of misconceptions surrounding different family planning methods. And unfortunately, it's somewhat perpetuated by the providers. So I completely agree that there needs to be a way to identify exactly what these myths and misconceptions are, misconceptions, where they're coming from, and how we address them appropriately with, culturally appropriate messages and messages that are going to make a difference. And the fact that those misperceptions there just in the general family planning realm, it just gets, really even more intensified when you're talking about somebody who's HIV positive and on ARVs. So I'd like to agree with you folks on that one. And then I just wanted to add, you're talking about the assessments that just happened in Cambodia that Marta was a part of. As soon as we receive that report, we will put a public version on the deck, which is USAID website that people will be able to access. So we'll make sure that gets there. And also, it's just great to hear from our folks, and hopefully we just keep the lines of communication open in terms of the challenges that others are facing and how others are attempting to deal with some of these things. Thanks a lot.
Thank you, Robert. I think you are trying to open up a line for one last question from the phone. Do you have to deal with the question?
Hello? Can you hear me?
Yes, we can go right ahead.
I'm Lee Kine from Myanmar. I'm working for UNFPA. I would like to add on what Julie Kabasi from UNFPA Regional Advisor mentioned about the SRH and HIV linkage. Myanmar, we have HIV prevention program, and also we have the maternal and child health program. So these programs working together in some of the townships, some of the sites, and right now is what we are trying to link the SRH and HIV linkage, especially for most at-risk population, are the female sex workers. In the country, we have partner PSI, Population Services International, is working for the female sex workers through the drop-in centers. So in drop-in centers, these kind of reproductive services, the family planning services, and HIV prevention services are available. So, good modality, and we are planning to scale up this modality not only in the private sector, but also in the public sector. So this is my additional comment on how we are trying to link with the SRH and HIV, especially for the most at-risk population. Thank you.
And I think comment as well as some of the last ones, you raise a good point that I feel as if this webinar, you really should be seen as really the opening of a dialogue for communications between partners in different countries. I think often in global health, we're really great about communicating with one another within our own free programs and not necessarily so much outside of that, particularly on technical topics such as this one. So I think our hope is that this was the beginning of a discussion that can continue in different ways over time. I will be sharing a webinar report with everyone that will have contact information as well as a PowerPoint they're able to see on the screen. And if you have any questions about how to maybe get in touch with someone that you heard on the call, please don't hesitate to email me and ask. So I'll take this opportunity to just say good night on this side, although it's probably just good afternoon for most of you. And to just thank you again for your time. I know that this was, a bit long for webinar, but I think it's really useful to have the time then at the end to talk with one another about these critically important issues. So thanks again to our speakers, and thanks to all of you, and I'll be sharing more information very soon.
Thank you for joining us today. This concludes today's web conference, and you may now disconnect. Have a good day.
Thank you. Thank you.